Okay, good morning, everybody, and thank you for joining us for this morning's webinar, Endometriosis and Endotoxins, exploring the LPS connection with Kat Smith. I'm going to hand over straight to you, Kat, to introduce yourself and get going.
Good morning, everyone. I can't see you, obviously, but I'm aware that there are some familiar faces just from some of those interactions that we've just had. And Emma's just pointed out, just to remind everybody, that it would be really lovely to hear from you, to hear your questions, to hear your voice. So just once we've sorted that out, feel free to put your hand up. So let's get cracking. I know that many of you do know me, but some of you don't, I'm sure. I'm Kat. I'm the founder of Endoplan. I wasn't involved in anything female health at all for most of my adult life. I was actually a teacher in a secondary school, minding my own business, getting on with my life until I became really poorly, increasingly. Eventually, I was diagnosed with stage 4 endo, and I then had 5 surgeries before I realised that probably this wasn't going to be an effective solution for me. So, to cut a long story very short, I left my career in teaching. I went back to train as a nutritional therapist, a naturopath, and a nutrigenomics practitioner. And then as my business grew, I developed a practitioner program to help other practitioners to better understand and serve people with endometriosis. And in the last sort of year or so, I became aware via Charlotte of this test that we're going to be mentioning today, which is the KBMO gut barrier and fit test. And the whole reason that that came into my practice was LPS and the research around it. So today we're going to cover quite a lot, actually. We may not cover all of it. If we get really intrigued by certain elements, then that's absolutely fine. But we're going to develop an understanding of LPS itself. I'm going to touch on the nuances of functional testing because that's something I'm really passionate about, and why we make the decisions to choose the things we choose and why we might not. We're going to delve a little bit into the immune system, the involvement, and how we evaluate the immune system and deal with some of these endotoxins. We're going to touch on eating patterns and restrictions because that comes under the remit of this test. And then I'm going to pose some questions towards the end about how we actually look at structuring change for people with endometriosis, because of all the things that I talk about ever, this is the thing that I'm probably most interested and passionate about. So I shall continue talking until Em might stop me and a question comes up. So let's begin at the beginning and really take a step back. You may or may not be following me on Substack, where I've recently been talking a bit more openly and a bit more bluntly about why I use the tests I use and don't use the other tests. And that's not what we're talking about today, but what we must appreciate is that if we are going to be spending our clients' money on any kind of functional or other testing, particularly in this specialist area, I would argue, we have to be really thinking carefully about what we offer and why we're offering it. So I used DNA testing pretty much exclusively for the best part of 4 or 5 years, I would say, for many, many reasons. And some of these things I've just circled that I wanted to discuss. We do want data and we do want information for our endo clients. It's very possible they've had nothing of that sort so far. But one of the key considerations for me is that the testing that you do can often be impacted by, for example, the hormone therapy that many of your clients will be on, possibly by any supplements they might be taking, and all sorts of medical interventions. So we have to weigh up what's going to be really suitable and what isn't. But then, as the research on bacterial contamination and LPS came into the spotlight a bit more, I had to really examine what I was offering and examine what else I could offer to try and fill this gap of the bacterial-led drivers and symptoms. So, in fact, although, I mean, these are all linked for you, and so if you get a copy of the slides, you'll be able to explore them yourselves. Although we like to think that bacterial contamination hypothesis for endo is last few years, actually, we have really known about LPS and bacterial contamination long before that. It's just that it's now becoming really prevalent, and we understand the pathogenesis a bit more. So, first off, let's rewind and look at what LPS is itself, just in case we're not familiar. So, it's the lipopolysaccharides that are in the gram-negative outer membrane. So, I've just screenshotted an example here of a gram-negative bacteria. Now, there is a real sort of misunderstanding about biofilms and LPS. They're not the same thing, but they work synergistically to make our life harder. So all we need to know really at this point is that as part of that gram-negative outer membrane, we will have biofilm and we will have LPS, which is a component of that. And just to try and early doors make you aware of how resilient and toxic LPS is, we can see here that everything that happens with a biofilm and with LPS, they keep each other resilient. So particularly E. coli is well studied for this. We know that the LPS will adapt to increase things like adherence and resistance of biofilm. We know that it can become more stable. The biofilm becomes more stable because of LPS. And then almost like a monster from the deep, we'll see this in the next few slides. We know that LPS works with other extracellular components to complete biofilm. So you're hopefully getting the understanding that it's a very tricky thing to eradicate. So why is it such an enormously big deal with endometriosis? Well, it is because of what we now appreciate. We know that E. coli and Fusobacterium in particular have been very thoroughly studied and implicated in the pathogenesis of endometriosis. Obviously, these are both gram-negative bacteria, and obviously they carry high levels of lipopolysaccharides. Now, these bacteria have been found in generally twice as high quantities than in control groups. So women with endometriosis have much higher levels of these gram-negative bacteria. Fusobacterium, a little bit more recently, has been more and more studied to be found in the reproductive tract and linked to the development of the disease. And when we say endotoxins, it's such a powerful endotoxin because the trigger of the immune response is enormous. So if you want to go a little bit deeper into understanding it, then we're going to discuss a few of these bits, but the title on this slide is crucial to take a look at, because both your client's symptoms and the development of the disease are driven by LPS, amongst other factors, obviously. Now, that's quite unique in the sense that we can really pinpoint now, using this test that we're going to discuss, what is the LPS status of the client, and are these bacteria actually heightening the symptoms and creating regrowth? Quite often the answer is yes. So let's touch on a few bits of the pathogenesis in a little bit of detail, and then we want to get to some sort of examples. So angiogenesis. We know for sure that LPS assists angiogenesis. So once again, you've got this sort of new blood vessels forming. We've got the facilitation of new lesions potentially. that immune trigger that we've just talked about is vast and much too detailed and multifaceted to talk about all the little bits. But I've highlighted macrophages in particular, a beginning of this cascade. They respond to the LPS, and then you get the receptor complex, which I'll show you in a minute. And this is associated with hyperalgesia, so an increased pain. We get the reduction or the sort of attenuated T regulatory cells. So all in all, you can see the unraveling disaster that's happening in the immune system. Then, of course, the signal has started, it's gone nuts. We've got all the cytokines. We've got interleukins, we've got TNF alpha. We've also got fibroblasts and growth factors. So it's just the perfect storm for endoplaques, lesions, and cells to grow. And then there's a bit of debate about the figures when it comes to levels, LPS, gram negative. But what we can see from the research is that it's somewhere between sort of 60 to 80% of women with endometriosis are shown to have the LPS in the peritoneal fluid on testing. So this is absolutely significant. I've summarized a bit of research for you here. If you want to go into looking at how it travels, because that's kind of fascinating as well. This is the most concise diagram that I found, which kind of shows how we might get the traveling of the LPS. And these are the different sort of, well, question mark over some of them, but these are the hypotheses. I think the one that I've put in capital letters, which we're going to look at today, is intestinal permeability itself. And we can test for that. So here we are. It would be really nice. I don't know if you guys are able to, but it would be nice to see in the chat, if you wouldn't mind, just popping a yes or no. Have you used the gut barrier test? So the FIT test or the gut barrier test on its own? I'd really like to know how many of you have. So if you can pop in the chat. Is the chat working? Who knows? If it's not, don't worry about it.
If it's not Kat, there's always the Q&A that everyone can use. And also, I've also gone through everybody and allowed you all to talk. So if you want to come off of mute and talk at any time, ask any questions, anything like that, please do.
Oh, brilliant. Thank you. So yeah, you can even just shout if you're really passionate about it. That would be fine by me. So, I'm just going to open this Q&A bit here. Not yet. Yeah, awesome. Okay, so yes, some people have. Right. So for those of you that aren't familiar, just summarizing a little bit here, what the barrier section of the test is all about, and then we'll move to the food issues in a minute. So this is the updated version of the test. So there was a slight expansion of the test in recent months. What we have is a blood test, a tiny, simple finger prick test. And we're looking at antibodies, essentially. So on the left-hand side, this left column, we've got the IgG and the C3d, which I will explain a little bit more, but it's a complement cascade. On the right-hand side, we've got IgAs. So as I'm sure that you can ascertain, the left-hand side is more systemic and long-term involvement, immune involvement, and the right-hand side a more localized short-term involvement. Now let's look at the markers themselves. We have Candida, we have zonulin, occludin, and the all-important LPS. Now these keys are what I use with my clients to better explain to them what's going on. So obviously when Charlotte alerted me to this test, I was sort of apoplectic because having a very simple and very inexpensive LPS marker and quite a sophisticated one is sort of a dream when you only see endometriosis clients day in, day out. And of course, if you've used the test, you'll already know that the full FIT test comes with variations of different food reactions. Just in case anybody is not familiar already, this is not exclusively an IgG test. I would argue that traditional food intolerance IgG tests are a complete waste of time. What we have here is a much more sophisticated technology, which marries that up with downstream complement protein and inflammation. So the reason that that appeals to endometriosis clients is that they will finally get some actual real life data about which foods are creating inflammation, adding to endobelly. Because all of this stuff, and if you know me, some of you have worked with me already, you'll know that this is the bane of my life. As somebody with endometriosis, I can tell you that the level of fear around foods is absolutely unbelievable. And quite often, clients will come to me with a handful of foods that they eat because they're scared to eat anything. And is it any wonder when you look at all the things that could potentially have been suggested to them to avoid? It is truly terrifying. So this technology that we're using is different. The technology on the left-hand side, this is the conventional type of IgG bound test, which is really just what are my favorite food tests. It's not very useful at all. Whereas what we have with the FIT test, the food inflammation test, we see here that we're looking at the downstream complement proteins. So yes, we have the antigens, we have the IgG, but we're also looking at the C3D. That's actually a real tongue twister. And so essentially, we've got a much more meaningful real-time inflammatory set of data. Now, if you're a bit of a nerd like me and you want to actually look a bit more on what the immune complex really is, you can find it here and in this study that I've linked. But essentially, we start here and we can see that we've got the dietary fragments, and then we've got the passage through the tight junctions. We've got the presentation of the lymphocytes, and then we get all of these downstream inflammatory reactions. You've got the TNF alpha, and eventually, this is what I mean by downstream. It really is downstream. What is happening real time is the kind of the complement proteins. So this is much more meaningful for our clients. Okay, I'm just going to take a pause and check that nobody's asked me anything. Let's have a look. I can't see any questions as yet. Anyone want to quickly come off mute and shout or say anything? You're very welcome to do that. No? Okay, cool. So let's look at one case study in particular, and then I want to show you something a little bit more shocking for a second consideration. So here we have a 24-year-old woman with endo, history of ablation, excision, very long-term severe pain issues. Now, that's some of you already know this because you do this a lot, and some of you may not know this at all, but very, very severe and consistent pain is not necessarily something you're dealing with endometriosis, but this was very, very severe and unrelenting. There was very long-term constipation, bloating, digestive issues, omeprazole twice a day for 7 years. Marina coil was there, bit of thrush, and all sorts of other things going on. So we can see from just the barrier panel itself, LPS was very much driving, responsible for perhaps a lot of these symptoms. On the left-hand side, we see that Candida actually not an enormously big deal. We have the sliding scale to show where the cutoff is and what the kind of accumulation is, how high the bucket is, how full the bucket is. None of these things were really the big issue, but LPS very high, systemically longer term. So we can be pretty confident that there's a long-term bacterial infection here, most probably E. coli Fusobacterium. On the right-hand side, we see that actually there is a leaky gut issue, and we also have that localized LPS. So digestively, that is a problem as well. So what do we do about these issues, and how do we kind of target things when we've got endo clients? Well, we do have some known strategies. More on this in a second. We have to attack the biofilms. Now, biofilm disruptors, this could be an entire career in itself, just examining biofilm disruptors, because as you'll see in a moment with one of my other cases, it's really tricky depending on the severity and the resilience of the biofilm. But I'm sure you all know already, typical interventions might be things like oregano, NAC, serapeptase, etc., etc. There's a couple of examples there that I would use. We need a broader antimicrobial protocol, of course, both in terms of diet and in terms of supplements, especially if we're looking at an infection of that level. By the way, it's worth pointing out here that you could also refer a client with this severe infection to seek a medical protocol, so antibiotics, in case that's something you're interested in. A little bit tricky because you would need two different types of antibiotics, but just a heads up on that. Vitamin D, which I'm always banging on about, becomes exceptionally important, and in fact, a higher level than you might think, which will kind of help the T regulatory cells and get LPS in check. Omega-3 has been shown again and again also to try and reduce LPS and to try and reduce gram-negative bacteria. Probiotics, yes, some kind of different information about different ones and which ones are best for which situations. But acidophilus NCFM comes up quite a lot, and there's a study there. The type of fats that we eat, this comes up a lot in the literature as well. If we have a known LPS issue, then in anti-inflammatory fats and the need to reduce omega-6 seems to become dietarily becomes even more important. Of course, you generally need to run before you can walk by strengthening the microbiome itself. It's not just about supplements and all the T regulatory cell support that you can muster. So this was the client's set of food reactions. Now, I think you won't be too surprised to hear me say that I personally don't want any of my clients to be ingesting cow's milk, because really there's no reason for it. We know that cow's milk itself, whether or not you've got an antigenic cascade reaction, by the way, it's not a good thing for endometriosis because of the A1 protein, because of the casomorphine. But that being said, on my results, I didn't have any kind of dairy implicated or gluten at all. So that was not an antigenic reaction. What's really interesting is that some people will react to completely innocuous things, things like really random things like carrots or salmon or butternut squash. So this gives us a level of specificity that we just don't have otherwise. I mean, melon, I can tell you that this client did not think they had any issues with melon or peach or anything else. It also gives us a little bit more information as to whether or not an endometriosis client should be consuming any gluten. Now, you might say, well, you just shouldn't. And that's not very helpful, because we know that 75% of those with endo will benefit from excluding it completely. And of course, we know that gluten exacerbates immune dysfunction. But actually, I can tell you, having seen hundreds and hundreds and hundreds of people with endo, a significant percentage are fine on a low gluten or occasional gluten diet. And it really is important to consider what they want also in their diet and in their life. So this might give us a little bit more information to be able to say with accuracy, okay, well, yes, you have to test those things in practice, obviously, and monitor, but are there any enormous downstream reactions when you eat it? So this is very useful. I've got to admit, and I don't want to, that ginger comes up quite a lot. Now, is it because people are eating tons of ginger? I don't think so, actually, because even in the case when people are not including ginger regularly in their diet, their tea, or their supplements, we see it sometimes. Turmeric comes up a lot. And I won't go down that rabbit hole because many of you know how I feel about random turmeric use. So there's a huge array of foods, and this is incredibly useful. Let me pause. Do we have a question here? Okay, Rochelle. It's not my choice because I'm not a doctor. I don't offer antibiotics. So what I do is I give the client the two options. Now, if they've already invested in working with me, it's more than likely they want to continue down the natural antimicrobial, etc. route. However, there are instances where perhaps they're going to be better served by just getting on with some antibiotics. If they can afford to seek out some private medical care for that. Perhaps if they're just in such a bad state that they're not going to be able to take part in what we're about to talk about, which is a pretty rigorous process.
Thanks, Kat.
Katie.
I think you can you hear me, Kat?
Yep.
Thank you. That's really helpful. No, because I've been in a situation like this with a client. She didn't have endo, but she was struggling with polycystic ovaries and struggling with fertility. And I gave her the option. I said, there is the option of antibiotics and the option of natural antimicrobials. And she was like, well, what do you think? And obviously I can't advise. So it was that kind of, I was like, it's completely up to you. But she was like, eventually she was like, okay, let's go down the natural route. But it was the fact that she kept asking me what I would do. And I
Yeah.
was like, I can't advise you.
Well, you're right, but I mean that's really tricky because in this exactly the same way as you're describing, I get asked what people should do about surgery and hormonal medications, which of course is something that I absolutely couldn't comment on. But I think the thing to do in that situation is to be really, really blunt about the pros and cons of each approach. So I just kind of say, right, if you want to go down the antimicrobials, biofilms, etc., it is going to cost you some money. It's going to be quite detailed. We might be removing foods. This is like a pretty big task. If you don't want to do all of that, then you can invest more money to go and see someone to try and get some antibiotics and then deal with the aftermath. Kind of all you can say, isn't it, Rochelle? I think.
Yeah, good. That's
No,
kind of what I've been saying. So that's really helpful. Thanks, Kat.
no, 100%. Katie, if dairy and gluten have been removed, it probably wouldn't show as an immune reaction. Ah, maybe, but there's also the very real kind of patterns of not cross-contamination. M? What's it? Cross-reactivity? I can't, my brain's gone. So for example, when I retest clients and perhaps they have then been really religiously excluding gluten, just as an example, you might find that chemical compounds, similar things, proteins, are now rearing their heads. So this is really interesting. You might get oats, corn, all sorts of things. But it's not always the case that removing something from the diet completely kind of removes that reaction because we're not just dealing with IgG, don't forget. So it can be the case that I had something, I can't remember what it was in my test, which I never eat ever, and it was like a level 4 reaction. So
What 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 we tend to find, sorry, Kat, to jump in, Katie, in theory, you're right. Particularly if dairy and gluten has been removed or anything's been removed for a long period of time. If it's been removed sort of within a week or so, then we have got the chance that it's going to still come up. As Kat said, we have some cross-reactivity possibility. But primarily what we tend to find in this situation is that perhaps we haven't got 100% compliance. So as we know, dairy and gluten is in everything. You have to be so fastidious when you're really checking all the labels and we've got situations, have they eaten out in the last few weeks? Have they prepared anybody else's food that has those components? You know, you've really got to drill down if they're coming up and the client swears they're avoiding them. Really, really drill down to make sure that that is 1,000% the case, because very often it is possibly not.
Yeah, thanks, Charlotte, I think you've answered your own question there. Yeah, that wasn't an exhaustive list of biofilm disruptors that I just gave. I would say that like berberine does all the things that you said, obviously. For me also, I have people's DNA as well. Berberine has some indications with certain genetic SNPs. So that's all I would say, is just to be careful of that. But yeah, of course, it's an option. There are many. All right, so just a very, very simple idea of how you might deal with an endo client who has a significant LPS issue. So once again, this is not an exhaustive kind of, this is what you should do with everyone, and it's just an idea. So I like to take mine in perhaps a rotation of two different sets of stuff. You could do more, you could do less, but so prep, crucial. People with endo in particular tend to have horrendous methylation and detoxification issues. That's a conversation for another time. But prep would involve, and I've got a slide in a second, all kinds of kind of like support before we get stuck in phase one. So you choose your antimicrobials that you think are best adapted for the situation, whether it's Candida, by the way, or LPS, with a biofilm disruptor of your choice. And of course, you're not going to neglect other gut support. And I'm not going to offend you by going through what that is. Stage 3, do you rotate? Stage 4, back to phase 1. Stage 5, back to phase 2. Now notice that I've also changed the biofilm disruptor, and that's an option as well. So you kind of think about how aggressive you think the situation is and how long-term it's been. And then, of course, you've got a maintenance job to do as well at the end. So without kind of speculating about your clients, some general advice: each stage, the duration of what a stage looks like. Kat, how long are we doing this for? How long should each stage be for? Well, I can't tell you that, but it will depend on how severe the LPS is. So what's the load sliding scale? How long do you suspect the gram-negative infection has been going on for? So that's looking at the history. You must bear in mind the client capabilities and their endurance, and oh, there's a typo, the budget as well, their budget. So here's my biggest pet peeve is practitioners who will just give a protocol of however many months, and it's really, really difficult. But if you're honest with yourself, the client is not capable, for whatever reason, of executing all of that. So we have to be really mindful when we're designing this. And as I just said, very special attention needs to be paid to improving detox pathways, improving methylation in particular, before you start to add any of these aggressive measures, because you will know if you've done it, if you've perhaps not done it quite as carefully as you should have done, that we as individuals with this inflammation, with the immune dysfunction, with detox issues, we can become very, very sick very, very quickly if there's no support in place. So again, discretion on time frame. Binders, bile support, chelation. Do you want to use stuff like, I mean, I really like Biosin GI Detox. Toxiprevent is another kind of option. But then for me, I'm going to be using their DNA. I might have a methylation pathway as well. So that's a whole nother kind of level of detail. Let me pause, Q&A. Katie, I've been gluten-free for 30 years and have the genetics for celiac, definite sensitivity to gluten historically, and my came back. Yeah, 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 yeah. So it depends on what kind of immune sort of reaction is going on, when it's going on, and if there is that cross reactivity. It is fascinating, and I completely agree with you. It is complicated as well. Okay, what do we do with the food stuff? Okay, what do we do? What are we supposed to be doing? Now, Em will be able to give you and refer you to the more official protocol for the removal and the reintroduction of re-challenging of foods. This is what I do. I go for a 2 or a 3 month removal, depending on the capability of the client and what's going on. And usually this forms part of that preparatory phase. You could do, obviously, the preparatory phase separately to the food removal, up to your discretion. Alternatives, if there are lots of foods, and often there aren't. Sometimes it's just this little clump, bit more about that in a minute, this little group of foods. Sometimes there's hardly anything, sometimes there's loads, but alternatives, of course, need real consideration. I like to opt for a longer prep phase if I can, if it's possible. And then the reintroduction is structured. I'm not going to talk about that in huge detail because, again, Em can forward you to all the resources that are very, very clear from KBMA on this. But you structure it very carefully to make sure that you don't create this excess antigenic load again and you end up back to square one. The vast majority of foods can be tolerated if you reintroduce them carefully enough. Not all of them. So I would say that, of course, because gluten has other indications and other issues, that might be one that lots of people can't reintroduce. So for the case study that I just showed you, I wanted to split this up a little bit so that you can see what happens in terms of symptoms. It's not always plain sailing, and you'll know this not just from endometriosis, you will know this from other work with gut health clients. Sometimes there is a consistent improvement, but sometimes you will have a real plateau and a real die-off, horrendous reaction. But even at the beginning, this client had really, really good improvements in digestion. Stool is more regular, craving blood sugar, not getting headaches and nausea. Yeah, so that's early doors. And then you can see she had a bit of a, by the time we were on to sort of phase 2, when we rotated, that created a little bit of a backlash, which is entirely understandable given the amount of endotoxicity going on. Time check. Oh, I'm actually not doing as bad as I thought. Now, this is, I was kind of in a tussle as to whether or not I should include this, but I decided that I would. So I hope I did the right thing. Let me pause. No, I don't always do a methylation report. I always do a hormone panel and then maybe a methylation report. Did you say that helps you to decide how many binders they need? I didn't say that, but no, because my methylation, the work that I would do as a result of the methylation genetics, binders wouldn't be like the first choice of action. It would be really dependent on, it could be anything. It could be that they've got a real folate cycle issue, could be that it's choline issue. Nadia, can I speak more about methylation support and detox? Yeah, but I guess, Nadia, the thing is, what I was just explaining is I'm using their genetic panels to ascertain what kind of methylation and detox support they need. So I don't believe in just kind of doing random stuff. Like, I really want to know what's going on. So methylation wise, there's 6 cycles that I'm looking at their genetics to see what's going on. I can kind of touch on really sort of generic measures, if you like. So generic measures might, but even in this case, like, you know, there are pitfalls. So really generic methylation and detox stuff, I'd be looking at maybe using some methylated folate and B vitamins, but then there's a contraindication if anxiety, mental health is a problem. So that's a little bit choline. If there's one thing I would suggest for methylation, look at their diet and see how much choline they're getting. Because if people are vegetarian, vegan, if they don't eat eggs, they're going to be disastrously low on choline. So that's another thing to look at. Detox, you know, this could be a whole nother presentation. So looking at the lifestyle factors, really the simple stuff as well. Are they moving? Are they sweating? Are they peeing? Are they pooing? All of that stuff. Rochelle, do you always do a read? No, I actually rarely do. Because it involves a big investment again for the client. But this was interesting. Let me explain this because it kind of looks shocking in the first instance. So this is a client I have been working with for years. And she likes to do everything that she possibly can, and she has the budget to do that, and that's up to her. So we did July last year. This is the slightly older version of the test with no sliding scale. That's just coincidence. And you can see no candida, no LPS, terrible issues with gut permeability, barrier function. This year, we've got raging LPS, and we've got a better gut barrier. Now I'm going to just be captain teacher and ask you guys, would anyone like to unmute themselves and tell me what do you think happened here? This is a really hard question, but this is like playing detective. Can anyone speculate as to why this might be the case? There's no wrong answer. I'll tell you what happened, but I'd love to hear what you think. Okay,
I'll suggest, Kat.
go for it.
I'll play captain student.
Yeah.
I'm going to guess in the first instance that the work you were doing on biofilms was coming to fruition.
Yeah, so you're absolutely right. It was the context of when these tests were done and what we'd been doing. So the July test directly followed a 4-month protocol of microbial and biofilm work. Thorough, you know, nothing slapdash about that 4 months, really thorough. And so we thought, oh, we've won. Okay, great. We've managed to, it was very clear from her symptoms that there was some serious dysbiosis, some serious bacteria and some serious candida. And I thought, oh, this is great. Wow, that's worked. But we've got some real damage going on, which we then really pushed to get that gut barrier much more healthy. And then we decided to do a retest, and can you imagine? Can you imagine my level of panic and dismay? And what we then found out when we looked at this in a bit more detail is that the length of time for which this client had had extensive LPS meant that the resilience and the adherence of the biofilms was so sophisticated that even after a really hard going 4 months of work, they managed to survive. You know, and it's very much like candida going into spore formation. It's a bit like that. So I reached out to some of the specialists at KBMO, some of the specialists in the States. And one of the things that I learned is that sometimes you need to go even longer than 4 months. And you might need to create a few more boundaries as well in terms of very, very specific probiotics, specific formulations, etc. So I show you this just to let you know that if it's the route you want to go down, it's very much weighing up. I really, really don't like to give people with endo rigorous long-term protocols unless they are physically and mentally capable of doing it. And this person was. But yeah, it can be tricky for sure. Question. Yeah, exactly. Now, one of the things that I love about using this test is that just when you think you've seen it all, you haven't seen it all. Sometimes you see really odd patterns. Sometimes I see results where there are no barrier issues, no bacterial issues, no yeast issues, no permeability issues, clean, green, and then some really obvious clustering of food reactions. Clearly, as we've just said, it can be, people can overexpose themselves to foods. Yeah, okay, fine. But I get the feeling, and this is a hypothesis as much as anything, that this sort of points towards an immune sensitivity. And I don't mean to foods, I mean immune sensitivity. And I just quote this piece of research here just to remind us about the nervous system and the state of the nervous system in endometriosis often, which is understandably really, really in a terrible, terrible degenerative state. Now, if that happens and you think, oh God, nothing's coming up on here on the barrier, that's great because you've excluded the bacterial drivers, which is really worthwhile. This is the picture I get when there's long-term or just unresolved trauma. And then, of course, we're looking at referrals for different kind of support that the clients can get, as well as making our own recommendations about nervous system support. So sometimes also it's the starting point I've mentioned here. Sometimes a client has a better starting point in terms of their food and lifestyle. And actually it's more to do with this unresolved trauma. When we are doing those food eliminations and reintroductions in this picture of sensitivity, I think it's important to note that we need to use antimicrobials very, very gently if we're going to use them at all. So, if there's a little bit of residual this or that or the other, we want to be really, really careful, or we want to use foods instead. We might look at stabilizing mast cells. We also are going to go focus maybe on estrogen metabolism and receptor support, because if we've excluded bacterial influences, then we might turn our attention towards towards hormones, towards antioxidants as well, and of course, as I've just said, to nervous system work. Would there be any safety concerns with extending antimicrobial 6 months? Would you lower the dose? Okay, so 6 months of antimicrobials and biofilm disruptors in itself, without any other kind of red flags, is a possibility. It is a possibility. In terms of the dose, I don't tend to kind of go lower if they're doing it longer. That's probably not what I tend to do. I probably tend to kind of use those phases. So it could be that phase 1 has like the phase 1 set has a certain dose and the phase 2 set has a certain dose. So does that make sense? So you're kind of revolving it in that way. Would I classify Toxaprevent as a biofilm disruptor? I mean, I'd classify it as more of a binder and even a histamine kind of detox thing. Unless I've completely forgotten that there is a biofilm disruptor in Toxaprevent. I'm sure somebody will tell me if I have forgotten that. But yeah, I would classify that as kind of binding support. So when we start to remove the food clusters, it's very quick progress, which is great. So that's an incentive to continue things along. And I don't mean to sort of teach you to suck eggs, but we're not just looking at digestive symptoms, of course. We're looking at mental symptoms, often cognitive function. And then when we rotate, here we go, backlash. A few negatives, not surprising. So my clients are very well educated. Thrush flare-up, cravings, endo pain, fluctuating, hormones, da-da-da. So again, this is just my way of telling you, reminding you, we have to be extremely careful. And these are the people that will need continuous support. So I would definitely not be giving anyone a protocol and sending them off if we're doing something like this. This is regular hand-holding, unlimited support. So this is, as far as support is concerned, when we come to the end of our support together, me and my clients, this is a kind of conversation. Are you comfortable with your protocol? So your management protocol, maintenance protocol, are you comfortable with that? Do you know what you need to do? And then I'm okay for support at the minute. I'm fine. I don't need to do any more. Okay, great. And then you check in. So you just have to scaffold that really carefully. This is cute. I'm excited to see how I'll feel by phase 6. So yeah, it's a long-term thing. Have I got any unanswered questions? I don't think I have. Okay. So, perfect timing. This is the bit that you'll know if you've worked with me already, or if you're in my practitioner program, you'll be familiar with this, but I feel so passionately about it. I'm sorry if you know this and you've got loads of endo clients, but if you haven't, your protocol is only as good as your client's ability to comply and execute it. And if you're not really aware of the kind of change-averse pattern of the endometriosis brain, then this is something you need to really look at. Most often when I'm working with practitioners, and there's always like, compliance, and I think, well, compliance actually is not just the client's responsibility, because if you're the teacher or the practitioner and you've made something inaccessible, then you've done a disservice yourself. So we have to really weigh this up. Is it realistic? How complex is it? Have you looked at the food? So for example, this is just a thought that I've used a couple of times. If you've got someone whose starting point is terrible, their ability to sustain attention or to follow through with anything is really bad, and they've got a ton of foods, do you have to have them avoid all of the yellow reactions, the 2+ reactions, for the entire time? Well, yes, ideally you do. But if that is going to mean that they're going to collapse under the pressure of it, do we have to kind of rethink that decision? So looking at the bigger picture, how much support is there? Are they tracking anything? So yeah, this is all stuff that we need to be really aware of. And we call this scaffolding. We have to scaffold the process. And compliance, just to kind of finish on this note, because it's something that I personally believe that practitioners, mostly, obviously we are all different and some of us absolutely understand all of this, but mostly as a profession, we don't do well with this, especially with endometriosis clients. Compliance is a whole process which we have to scaffold, and it goes right from the beginning of feeling heard and seen all the way through all of these steps: confidence, tracking, belief, understanding, to get to a point where we're executing. So as much as this test is one of, well, as I've already said, it's one of 2 things that I use exclusively for endometriosis clients, we've got to be super mindful of what we're asking our clients to do, especially if our clients are particularly unwell. And the last page here, I've just got more key references that are focusing on the immune involvement. And then if you need help with this, me and Em were just talking about this. If any of you haven't ordered the fit test, and I know that Charlotte was mentioning that you can get a practitioner rate as well. If you haven't used it before and you would like to use it, maybe Em can tell us about that in a sec. But if you need help from me, you're really welcome to get the test. You can order that, and then you can email me. I can help you with interpretation, either for yourself or for your endometriosis client, of course, if that's what you need it for. And if you quote webinar, then we can arrange your discount for that help as well. Gosh, I'm bored of my own voice. Q&A. Oh, Em, sorry, did you want to talk about
Yeah, no, that's
yeah.
fine, Kat. And thanks so much. That was really, really great. Thank you. And oh, Rochelle has asked, thanks, Rochelle, what was the discount? So there is a discount for anyone who has never done the Fit 176 test before, which is the all singing, all dancing, 176 different foods tested, plus the gut barrier panel. And that is 40% off. So that would be £180 for the whole thing. All of the fit tests now come with the gut barrier panel, and you can get the gut barrier panel individually as well. So going back to talking about retesting earlier, something that's fairly common is that you might not necessarily want to retest all the foods again. You might, your client might. We tend to find that in fact, Charlotte often says, almost the first part of the test, the kind of food part, is the bit the clients really love. And then the gut barrier panel is the bit that the practitioners really love. And in reality, many of us love both bits, but you know what I'm saying. But you can, if you want to, retest the gut barrier only. As well. And actually, we have just introduced a special price on gut barrier retests, which takes them down to £75, which I'm going to email you all about a little bit later today. So that was that. Let's see if we've got, so you've got a question, Kat, about, can I ask about mold exposure and endo?
Yeah. Can you be more specific? Sorry, it's just an enormous question. So what is it? What is that question, do you think?
Ingrid, would you like to come off of mute? You're very welcome to come off of mute and expand if you like, or drop a little bit of expansion in the Q&A for us.
Yes. Can I ask a question?
Sure, please
Sure.
do.
Yes, I was wondering because I have myself endometriosis history, and I noticed that the previous house I lived had mold, and when I moved, of course, I changed the diet and I have full protocol about treating my endometriosis. But when I changed the house, now I don't have mold, and I felt really big difference. So I was wondering if it's really like affecting the mold endometriosis symptoms.
Yeah, so the most obvious route that we would think of when we think about that is the additional detoxification load that mold would have. So if we looked at your genetics as well, if I looked at your detoxification genetics, we might find potentially that there is some SNPs or variations on your mold metabolizing genes as well. Depending on what kind of mold it was, whether it's like the black, the name of it has gone out of my head. Everybody's screaming it. The black, what's it called? I can't remember. Toxin? No. We know that one in particular puts an enormous burden on the liver. So yeah, it would most certainly have slowed up your detox pathways, most certainly have impaired your methylation, made your hormone balance more difficult, potentially affected your estrogen metabolism. So yeah, it's just a huge burden. And there are studies linking mold exposure to all kinds of different immune issues. So yeah, it makes perfect sense. Yeah.
Great question. Great question. And actually, you've just made me think in terms of kind of extrinsic factors in the much bigger picture. Our next webinar next week at 10 o'clock is hormones gone haywire and why you should be testing for BPA. And that is in relation to the hormone insights test, or the HIT test, not the FIT test, but the HIT test. which essentially is powered by the ZRT Advanced Urine Hormones test. And as part of that test, we test BPA as well. So a little bit off tangent, but you just made me remember that.
There's so many great questions. So thanks everyone for getting involved. Is there anything that you want to ask me about this test or just about endo clients in general before we finish? Because I'm all ears if you want to discuss anything.
Get your access to Kat while you can.
Oh,
Is there a webinar on the HIT test then? Yes, there are lots. First things first, there are a number of them coming up, but also if you go to our website, kbmodiagnostics.co.uk, and you click on education, you will see that there are some webinar recordings, downloadable slides, etc. there as well.
Unmute myself rather than going back and forth. So would you guys doing the fit test and the HIT tests at the same time if someone has got endometriosis?
I use genetic testing. So that is the hormone testing that I currently use, and I use it along with this test. But as you will see, if you look at some of the resources and webinars on the HIT test, it is a valuable option to consider as well.
Yeah, so it's kind of, you would use the HIT test, for example, in place of a Dutch test, kind of the more expansive version of the Dutch test. So if that's something that you're thinking about doing with your endo clients or any other client, then there's no reason why you couldn't run the two at the same time. Just depends, I guess, on what they're looking to see as well, doesn't it? Really.
Yeah.
Nipping back, I'll have a look at the sample report. Pleasure, no problem. Just nipping back actually to the gut barrier panel. We will actually be at an event called Gut Health Protocols in London next weekend, Saturday the 8th of November. So when I send out the recording for this session later today, I'll include some information on that as well. They've given us a lovely discount for you guys too, which gets you 50% off of the tickets. So hopefully we will see you there if you'd like to expand on your knowledge of assessing and addressing food-mediated inflammation and also the gut barrier.
I'd like to come, but I'm not in the country, but that sounds really interesting.
It's a short flight away, Kat. It's a short flight.
Yeah. But then there's a ferry and then there's another ferry.
Yeah.
So
You're forgiven.
thank you. If anyone wanted some, like I said before, if you need any help or questions about getting help with your endo clients, you're very welcome to email me, kat@endoplan.co.uk.
Fabulous. Thanks so much, Kat. And thank you everybody that's joined us this morning.
Thank you for having me.
Lovely. Hopefully we'll have you back again very soon.
Lovely.
And we will see the rest of you next Monday, I hope. See you soon.